Okay, good morning. Let's begin. Start with the tongue. Okay, so the tongue is a muscular structure. We know that. Okay, it forms a part of the floor in the oral cavity. Also, part of the anterior wall of the oropharynx. So the tongue, as you can see, it has different parts. This is the apex of the tongue. Then this whole thing is the body, and the part by which it is attached to the inferior surface of the oral cavity is called the root of the tongue. And this part is called the inferior surface of the tongue. You can project this apex anteriorly so that the superior part and the inferior part they can extend, right? So it also forms part of the oropharynx, the anterior wall of the oropharynx. In the superiormost part, this one, this area, this is formed by the tongue. Okay, so pharynx, has three parts: nasopharynx, oropharynx, and laryngopharynx. This oropharynx is formed by the tongue. Okay, the root of the tongue, as you know, it is attached to the mandible and the hyoid bone. So this is a cross section of the mandible. Here is the mandible in the jaw. So this is attached to the mandible anteriorly and the hyoid bone posteriorly. Okay, and so this whole tongue musculature is attached here. Okay, so this is the attachment of the tongue. And in the oral part, this superior surface is divided again into two parts actually. Part is the anterior two-third. This is the posterior one-third. Now the whole superior surface is divided into anterior two-third and the posterior one-third. Okay, and this actually the anterior two-third is the oral surface and the posterior one-third is the pharyngeal surface. So this part, the posterior one-third, forms the anterior boundary of the oropharynx. Okay, so the anterior two-third and posterior one-third is divided to, demarcated by this V-shaped sulcus. This is called sulcus terminalis. Okay, so the lingual papilla, circumvellar papilla, they are present here. Okay, then in the posterior one third you have some tonsillar tissue called the lingual tonsil. Okay, and in the anterior two third you have the filiform papilla, fungiform papilla, all these things. Okay, and at the tip of this V-shaped sulcus there is a small pit. This is called the foramen cecum. Okay, so here is the tongue, and the foramen cecum is actually the point where the thyroid gland develops. Okay, the thyroid gland develops from the base of the tongue actually. From the foramen cecum in the junction of anterior two third, posterior one third of the tongue. Then it descends downwards like this, and then it forms the thyroid gland below. Okay, so function of thyroid gland, it makes and stores the thyroid hormones, and this pathway is called the thyroglossal duct. So different papilla are found in the tongue if you see under microscope. So one is the filiform papilla, okay, then one is the fungiform papilla. Fungiform papilla is like a fungiform because it is like a fungus. Then there is the circumvellar papilla. The characteristic is that the circumvellar papilla all around it is surrounded by a sulcus. Okay, and all these papilla they have taste buds. Then there is something called the foliate papilla. So the locations are also different. The filiform papilla is the most common and it is present all over the surface of the tongue. So it is found all along the entrance. The fungiform papilla is found mostly towards the tip of the tongue, also towards the edges. The foliate papilla is the most rare and it is found like towards the posterior part of the tongue on the side, okay, in the corner. And the circumvellar papilla is layer present in a single layer in front of the sulcus terminalis. Okay. Okay. So this is the filiform papilla. It is cone shaped. Okay, and in the surface, in not in humans, in some animals, it is keratinized. The tip is sometimes keratinized. Then this is the fungiform papilla. It's more present towards the tongue margins. Okay, they're involved in taste sensation. Okay, so they have taste buds. Then the circumvellar papilla, they are the largest papilla. Okay, and they are most sensitive to the bitter taste. And as you can see, this sulcus around the papilla, it has taste buds. So these are the taste buds. And the foliate papilla, these are a little bit rare and very less in number. Okay, they are just in two groups on either side of the tongue. But remember, in the pharyngeal surface, there is no papilla. Pharyngeal surface means posterior one third of the tongue, this part. Okay, there is no taste buds here. All taste buds are concentrated to the anterior two third. Okay, so there are different muscles. So one is the intrinsic muscle and the extrinsic muscle. So the intrinsic muscles are this one, superior longitudinal, which is along the length of the tongue, then vertical, which are up from superior to the inferior surface, then transverse, which are the horizontal muscles. There is one septum in the middle of the tongue, okay, which divides the tongue into two parts, two halves, and all these muscles they are inserted into this septum. Okay, so these are the intrinsic muscles, which are present inside the tongue. Okay. Now there are some extrinsic muscles. Like extrinsic muscles are those muscles which are attached to the tongue from some other structures. Like palatoglossus comes from palate. Glossus means tongue. Okay. Palatoglossus means it comes from the palate to the tongue. Styloglossus means it comes from the styloid process to the tongue. Hyoglossus comes from the hyoid bone to the tongue, and genioglossus. Genioglossus comes from the genioid tubercles in the mandible and to the tongue. Okay. So these intrinsic muscles, the functions is to alter the tongue shape. So if these longitudinal muscles contract, then the tongue will shorten. If the transverse muscles contract, then the tongue will become more cylindrical. And if the vertical muscles contract, the tongue will become flat. So knowing the direction of the fibers, you know how these muscles they act. They can act in pairs from both sides, and also they can act individually. Okay, then this is the superior longitudinal and inferior longitudinal. There are two longitudinal muscles actually. So this is the longitudinal muscle. I will not go into too much of details. Okay, so transverse muscle, this is the function. When they contract, they make the tongue more thin and longitudinal. I mean, more cylindrical. Okay, so these are transverse muscles. They go horizontally. So and again, there are vertical muscles. They will make the tongue flat. So these are the extrinsic muscles I already told you. Genioglossus, hyoglossus, styloglossus, palatoglossus. So they don't really alter the shape of the tongue, but they are concerned with the movements of the tongue. For example, protruding the tongue, retracting the tongue, depressing the tongue, elevating. Okay, all these movements of the tongue is done by the extrinsic muscles. But alteration of the shape of the tongue is done by the intrinsic muscles. So I'll not go into details of this again. Genioglossus, hyoglossus comes from the hyoid bone. Then styloglossus comes from the styloid process, and the palatoglossus it will come from the palate or the palatine aponeurosis. So blood vessel, one is the lingual artery. Origin is the carotid artery in the neck. Okay. Then there are some veins. One is the deep lingual vein, dorsal lingual vein. Okay. Just knowing is like sufficient. Okay. So this is the artery, and you can see this vein when you make the tongue upside down. Okay. This vein can be seen if you look in the mirror, and or you can look at each other's tongue and make the tongue upside down. Okay. Then under surface of the tongue you can see these veins. Nerve supply is there is motor supply of the tongue is from the hypoglossal nerve. Okay. Only the palatoglossus muscle is innervated by the vagus nerve. Rest all the muscles are innervated by the hypoglossal nerve. Okay, this is also known as the muscle of the tongue. And for taste sensations, you have mandibular nerve, lingual nerve, facial nerve, glossopharyngeal nerve. Okay, so different nerves are there. Okay, so the chorda tympani branch of the facial nerve is for the anterior 2/3. Okay, glossopharyngeal nerve for the posterior 1/3. And for the other sensations apart from taste, you have the branches of mandibular nerves, lingual nerve, okay, which supplies the normal sensations like touch, pain, temperature, all this. But for taste sensations, there is different nerves for different parts. Anterior 2/3 by the facial nerve, made it a chorda tympani branch, and the posterior 1/3 by the glossopharyngeal nerve. So different tongue diseases are there. Okay, there is glossitis, which is inflammation of the tongue. There is something called geographic tongue. Okay, different diseases are indicated. Ankyloglossia is the disease in which the tongue is tight. Okay, so you can't protrude the tongue; it is like fixed to the undersurface. So you need a little bit of surgical incision, and of course there is oral cancer which affects the tongue. There's something called sleep apnea. What happens during while you are sleeping, the tongue muscles relax and it falls back and closes the airway. Okay, it leads to snoring and all these things. So this is called sleep apnea, and there is a YouTube video where you can just go and see some exercises. And of course, the tongue has many important functions, so you need to keep your tongue safe. Okay, I'll go to questions, but before that, we'll talk about the esophagus. So what is the esophagus? So esophagus is actually the tube by which the food goes from the oral cavity to the stomach, right? From the through the pharynx. Actually, it starts from the pharynx and goes to the stomach. Okay, and it is in front of the vertebral column and goes through the first. It enters the superior mediastinum and then goes to the posterior mediastinum. Okay, so where does it begin? It begins in the neck, and the landmark is inferior border of the cricoid cartilage. So cricoid cartilage is a cartilage in the larynx that you can feel on the anterior part of your neck. Okay, so there the cricoid cartilage, from the cricoid cartilage to the cardiac orifice of the stomach, which is present against the T11 vertebrae. Okay, and its function is that it carries the chewed food and liquid from the oral from the pharynx especially to the stomach. So this is the esophagus here. You can see. Okay, it goes in front of the vertebral column, behind the trachea, alongside the aorta, abdominal aorta. Okay, so this abdominal aorta, the branches will supply the esophagus. It will pierce the diaphragm against the T10 vertebra and enter the stomach at the T11 vertebra. Okay, so this here is the cardiac part of the stomach. This is the fundus. This is the body. This is the cardiac area, cardiac part of stomach. Okay, so this part of this is the esophagus entering into the stomach. Okay, it's also associated with the vertebral column, trachea, and the aorta. So first it enters the superior mediastinum and then it goes to the posterior mediastinum. Okay, so length is about 25 centimeter, width is about 2 centimeter, and the lumen it is flattened anterior-posteriorly. Okay, so the lumen of the esophagus it is flat, it is like closed normally. Only when food is passing through it, it opens up. So here you see it has different parts. The most superior part is, if this is the cricoid cartilage, this muscle which is a part of the larynx is called the cricopharyngeus. This forms the superior sphincter of the esophagus. Okay, so the first 4 centimeter is called the cervical part because it is in the neck. Then next 20 centimeter is called the thoracic part, which is present in the thorax, and the last 1 to 2 centimeter is present in the abdominal part. Okay, so in the abdominal part, as it pierces through the diaphragm, the muscles of the diaphragm, it kind of acts like a sphincter, but this is not an observable anatomical sphincter. This is just a functional sphincter because they act as a sphincter. Okay, but there is no muscle thickening as such. So the cervical part, thoracic is 4 centimeter, thoracic part is about 20 centimeter, and the abdominal part is about 1 to 2 centimeter. Okay, the narrowest part of the esophagus is its commencement at the cricopharyngeal sphincter. So this part where the esophagus begins, this is actually the narrowest point of the esophagus. Okay, so this is another diagram. Here you can see other relations. The bifurcation of trachea is shown. Okay, where it pierces the diaphragm. So it does not pierce the central tendon. Central tendon is pierced by the inferior vena cava. Okay, this is actually the level T8. This is pierced at T10. It pierces the muscular part of diaphragm. So the muscles of the diaphragm, they form a sling around the opening of the esophagus here. Okay, and then posteriorly you have the opening for the abdominal aorta. Okay, so there are two curvatures of the esophagus. One is the side, the first is at the root of the neck before entering the thoracic inlet, and the second is the curvature before passing in front of the descending thoracic aorta. So it is curved in 2 points. You see this part is curved, and another point it is curved superiorly. Okay, let's see this. Okay, so there is one curvature here and one curvature above. Okay, so the esophagus is curved in 2 points. And also as the spine curves, the esophagus also curves along with the spine. Okay, first curvature is the curvature of the cervical spine, and second is the curvature of the thoracic spine. Okay, I'm not going to too much of details of anatomical positions. Just remember that it begins in the midline at the lower border of cricoid cartilage, and the vertebral level is C6. Okay, and it ends in T11 level at the gastric orifice. Right? So this one here you can see the two curvatures. One is this curvature as it enters the neck, and the other one is curvature with the abdominal aorta. So there are some constrictions in the esophagus. This is important. The first is called the cervical constriction at the cricoesophageal junction. So when it begins here, the esophagus is constricted. So constriction means the lumen becomes narrow. So as the lumen becomes narrow, the size of the esophageal lumen, it becomes smaller. Okay, so that is the at the pharyngoesophageal junction. The second constriction is where it is crossed by the abdominal aorta. Okay, so when the aorta is crossing the esophagus or the arch of aorta, it will have the second constriction. The third constriction is when it is crossed by the left principal bronchus. So this principal bronchus, it crosses the esophagus, it presses upon the esophagus and makes the third constriction. And the fourth constriction is by the diaphragm. Okay, so at the diaphragm as it crosses, it has the fourth constriction. So what are the four constrictions? One, at the junction of the pharynx. Two, when it is crossed by the aorta. Three, when it is crossed by the bronchus. And four, when it is crossing the diaphragm. So why is it important? So these four places are the points where some foreign body, if it is ingested, it is most commonly lodged. Okay, these are the points where the esophagus tends to get narrow if there is constant inflammation and any esophagitis. Okay, so this is another diagram. It's showing different lengths from the incisor teeth. Okay, from the top incisor, the length of different points. First constriction is at 15 centimeter. Second constriction, okay, is at somewhere around 24 centimeter. Also, the third constriction is somewhere around that 20 centimeter point. Then the final constriction is somewhere around 38 to 40 centimeter. At 40 centimeter length, the esophagus joins the stomach. And this distance is not from the beginning of the esophagus, it is from the beginning of the incisor tooth. The two sphincters that are present in the esophagus are the upper sphincter and the lower sphincter. Actually, the upper sphincter is the anatomical sphincter, and the lower sphincter is actually just a functional sphincter. That means the diaphragm just acts as a sphincter, but there is no muscle that can be named as a sphincter. Okay. So if you're passing any nasogastric tube is a tube which is passed through the esophagus in case the person is not able to eat properly. Okay, so it is passed from the nose, and from the nose as the tube is sent downwards. So these 4 points are the points where you will find resistance. Okay, first you will find resistance in the pharyngoesophageal junction, then you will find another resistance here. Okay, so when you are applying the nasogastric tube, also called Rice tube, okay, so these are the points where you will find resistance, but that does not mean the tube has stopped going. You just have to push a little bit further. Okay, so what are the muscles of the esophagus? It has actually all the two main types of muscles. Both of them are there, the skeletal muscle and the smooth muscle. Okay, in the upper one third you have the skeletal or the striated muscle. In the lower two third you have the smooth muscle. Okay, and there is a mixture of striated and smooth muscles in between. I mean in the middle one third. Okay, so upper part is purely voluntary muscle. The lower one third is purely involuntary muscle and mixed in the middle. Okay, and externally the pharyngoesophageal junction appears as a constriction produced by the cricopharyngeal part of the inferior constrictor muscle. As I told you, this acts as a normal anatomical sphincter. Okay, so these are different diagrams in different views. Okay, this is from the anterior side, this is from the posterior side, this is from the lateral side. The relations you can see, this is the trachea in front, the arch of aorta, it goes posteriorly. It begins in front, then it arches over both the trachea and the esophagus and goes posteriorly. So this is the cross section where you can see the relations. This is the esophagus in the middle, then you have the trachea in front, and this is the arch of aorta. So this is the cross section taken at the level of the bifurcation of trachea. Okay, so this is the esophagus when it enters the stomach. Okay, so it has entered into the stomach here. This is the cross section. So I told you about the two sphincters. They prevent the entry of air and also they prevent reflux. The superior esophageal sphincter is an anatomical sphincter. I told you it is produced by the cricopharyngeal muscle. Okay, and normally it remains constricted to prevent entry of air. But when you are swallowing, it opens and it allows the food to go. Now the lower esophageal sphincter is just physiological sphincter. That means it is a part of the diaphragm muscle, but it is not an physically it is not definable. You can't go and see the sphincter. Upper esophageal sphincter you can go and physically see. The arterial supply of the esophagus. So different places, since it's a long tube, in different places, different arteries they give blood supply to the esophagus. Cervical part, it is supplied by the inferior thyroid arteries. In the thoracic part, it is supplied by the esophageal branches of the descending thoracic aorta and also bronchial arteries. The abdominal part is supplied by the left gastric artery and the left inferior phrenic artery. So in different places, different arteries supply the esophagus. Okay. Veins again similarly, inferior thyroid vein. In the thoracic part, azygos and the hemiazygos vein. Okay. And in the abdominal part, left gastric vein also uh, comes into play. Okay. Now, in the abdominal part, the last part, a small part is drained by the hemiazygos vein and another part is drained by the left gastric vein. So these two veins they join each other. Okay, but the hemiazygos vein is a tributary of inferior vena cava and the left gastric vein is a tributary of the portal vein. So this area is a place of something called portosystemic anastomosis because the inferior vena cava is a systemic vein that is taking the blood to the heart and the left gastric vein is a portal vein which is taking the blood towards the liver. Okay, so this area is a part of portosystemic anastomosis. Okay, we'll talk about this again in another class. Okay, lymphatics again, because it's a long tube, the different places have different lymphatic drainage. The superior third is by the deep cervical lymph node, the middle one third by the superior and the posterior mediastinal nodes, and the lower one third by the left gastric and celiac nodes. Just try to memorize. Okay, so the esophagus again has both parasympathetic and sympathetic nerve fibers. Don't go into details of this. So histologically it has four parts, all the entire GI tube has four layers: mucosa, submucosa, muscular layer and outer adventitia. Okay, just one thing, the mucosa, the lining epithelium is stratified squamous, non-keratinized. Okay, and in submucosa you have esophageal glands. In the muscle layer I told you, upper one third skeletal muscle, lower one third smooth muscle, middle one third it is mixed. Okay, now if the epithelium of the esophagus, which is stratified squamous non-keratinized, is changed to columnar epithelium, we call it a condition called Barrett esophagus. Okay, Barrett esophagus is considered to be a precancerous condition. Okay, so the epithelium, if it changes from one type to the other, it is an indication of incoming or oncoming cancer in future. We will not go into details. Okay, what is barium swallow? So in X-ray normally the esophagus is not visible. So to make the esophagus visible, we do something called barium swallow. Okay, so in barium swallow, the lumen of the esophagus can be detected in an X-ray. What is achalasia cardia? It is the condition in which the lower esophageal sphincter it fails to relax when the food is swallowed. So that what happens? The food is not allowed to enter into the stomach, and the food keeps accumulating in the lower part of the esophagus, okay, and it leads to a lot of regurgitation and a lot of inflammatory conditions and all in the lower part of esophagus. Again, similarly, there is something called esophagoscopy in which a camera is inserted into the esophagus to visualize it. Dysphagia is a condition where there is difficulty in swallowing. Okay, and different conditions may lead to dysphagia. Sometimes it is a condition of the esophagus, sometimes not. Now, tracheoesophageal fistula is a condition that is of embryonic origin or developmental. What happens here is that because the trachea and the esophagus actually developmentally, starts from a single unit. Okay, the trachea actually begins as a diverticulum from the gut tube, and the rest of the gut tube becomes the esophagus. Sometimes this connection is still there, and this produces a tracheoesophageal fistula. Okay, and it leads operation. So here, this part is the gastroesophageal junction, also called Z line, this area. Okay, and this is the point where the esophagus ends and the stomach begins, actually, the cardiac part of the stomach. Okay, and this line is the point where the stratified squamous epithelium of the esophagus becomes the columnar epithelium of the stomach. I told you about Barrett's esophagus, in which one type of epithelium changes to another, and this process by which anywhere in the body, any place where the epithelium of one type changes to another is called the metaplasia. In the esophagus, it is called Barrett's esophagus. Okay, so this is the condition you see. Z line should have been somewhere here, but here the Z line is shifted upwards. Okay, so this area is Barrett's esophagus. This is the endoscopic view. There is a lesion somewhere, and this ultimately leads to esophageal carcinoma. So the 2% of malignancies in the United Kingdom are esophageal carcinoma. In India also, sometimes the Barrett's esophagus has to be suspected to be a pre-malignant condition. That's it. Thank you.
Thank you, sir.
Okay, thank you.
Thank you, sir.